Hey guys, welcome back to the Wednesdays with Watson podcast. I am so excited to bring Jeremy Fox back to you as we are in May of 2023 and it is Mental Health Awareness Month. This is the episode that you guys asked for. These are listener questions and Jeremy is here today as always for educational purposes only. While he is a licensed therapist and we will talk about his modality today of EMDR, he is not here acting as your therapist. He is here for an educational purposes only. So with that being said, without further ado, Jeremy, welcome back to the Wednesdays with Watson podcast.
Thank you, Amy. Great to be here as always.
Well, my listeners love you just because we were just talking pre-interview. I was like, hey, Jay, just stop. Let me hit record because you just start popping these gems out. And so we're going to go right for it because the episodes with you are typically longer. They're well listened to, but I know the people want to know some information. And so some of the topics that came into me and we were just talking about this one. And so this first question, you said to me, wow, I could go so many different directions with that. So I'm just going to let you take it the direction you want. One of the questions, listener questions was, could you ask Jeremy, could you help us understand, because you and I were just talking about this, there's this, and I think you worded it beautifully when you said there's this witch hunt for women, it's this, and for men, it's narcissism. Everybody's a narcissist. And so one of the most requested questions was, could you help people understand what narcissism is and how to recognize it if they're in a relationship with someone who is a narcissist?
Okay, well, absolutely. So what my background allows me to do as a licensed professional counselor is diagnose mental health conditions, right? So narcissistic personality disorder is absolutely a disorder. So it's something that interferes with someone's capacity for interpersonal relationships. That is what a personality disorder is. And I was joking the other day and saying that a personality disorder is such an interesting term, right? It's very labeling. So I want to walk that line of, and we're going to go over some criteria here. I want to walk that line between dignifying, of course, people's experience with abuse, because I think we can really downplay that. And I think historically women's issues within a marriage have been dismissed and considered something to just get over and bear under. And I certainly would never want to encourage that. I'll underscore that. And also, I think that we can start to use terms as catch-all terms that really actually might not do as good a job of helping us understand the behavior going on as if we used other terms. And I think narcissist is kind of a term that can go along with that. And so per the Diagnostic and Statistics Manual 5, the 5th edition, which is the psychiatric Bible, the psychiatric field guide, right? It's what we in the therapy, you'll notice I'm saying psychiatric, I'm a therapist, we use the same diagnostic manual. Psychologists do, psychiatrists, therapists, social workers, all of us use that. And then the International Code of Diseases, the ICD-10, there's overlap there. And it's all about diagnosis and insurance reimbursement. So, but narcissistic personality disorder is what we refer to as therapists and licensed professionals. It's the condition there underlying that someone may have. And that's kind of the only standard structured way we can refer to that. And so that involves a grandiose sense of self-importance, right? So exaggerating one's achievements, being expecting to be recognized as superior without even completing achievements. And so that's per the Diagnostic and Stats Manual. People need 5 of these to qualify as having narcissistic personality disorder. So another one would be preoccupied with fantasies of success, power, brilliance, beauty, or perfect love, believing that you're special and can only be understood by others who are special or by special institutions. So prestige, excessive admiration, sense of entitlement, unreasonable expectations, exploitative and taking advantage of others. Okay, so now we hit on one that's very commonly discussed now, and we'll park it there in a minute, but lacking empathy, unwilling to identify with needs of others, envious of others, or believing others are envious of them, arrogant, haughty behavior and attitudes. Okay, so lots to take in, and I encourage everyone, if that was too fast or too much, just Google DSM-V NPD Criteria. And so I really want to caution against using this as a field guide and bringing it to your partner and saying, you have this, because think about it, it's really going to work. Even with someone who doesn't have narcissistic personality disorder, it'll be hurtful or angry. And especially if they have it, they're probably not going to just say, you know what, you're right, I admit it, the jig is up, the gang. So don't think that'll be how that goes. But the exploitativeness element there, and lacking empathy is what people often now will talk about in terms of narcissistic abuse. And so I think, so narcissistic abuse is actually a term that doesn't come anywhere from within, in my experience, and listeners can chime in. I think that comes from more within the coaching and peer helping professions. I think it can be valuable to think about terms like that in terms of a pattern, if that's there, of being, gaslit, which is essentially denial. It comes from a movie called Gaslight, where the husband makes the wife think that she's losing her mind because he makes subtle changes and denies things, and outright refuses to acknowledge reality. And so we could say that falls into that kind of exploitative element there, taking advantage of others. But you'll notice nowhere is gaslighting in the criteria, and that's not a mistake. The criteria for narcissism is much wider than that, and it could probably include that, right? But if you feel that a partner is denying reality, denying what's happening to you, and isn't just simply not noticing it, because, by the way, that lack of empathy and lack of attentiveness to others, or identifying with the needs of others, rather, both those things kind of can be entailed there. But it really might go to that. And someone might not be paying attention to your needs, and they might not be intentionally gaslighting. They might be just unaware completely because of the selfishness element. So how can you tell someone is narcissistic? Well, I'll give some actionable tips. I mean, it's on a spectrum all the way from some light, I guess we could say, preoccupation with self, all the way to NPD. So again, narcissistic personality disorder. In your dating life, is this person really focused more on himself or herself and relating everything back to their own needs, and not in a way to make to establish a bond with you in conversation, say, oh, I experienced much the same thing, let's talk about it, but in a way where they center their needs constantly, even when you gently remind them that you have something that you need. So be on the lookout for that, especially early on in dates. There's a joke that, and it's not really a joke even, but there's you can Google it, like a 1-question narcissism test. And the question is, are you a narcissist? And people who don't think that's a bad thing will say yes. So I would probably not ask that on a first date, right? But I would encourage you, notice if someone really doesn't see a problem with talking about their achievements and how they're better than others early on, because what often can happen is someone can be extremely charming and self-possessed and confident, and that is very attractive, right? So be aware of if this is confidence or overblown cockiness early on. And note, so that's on, because narcissism is really, you'll notice most of those things in that list I went over, again, you can look at it, DSM NPD Criteria, is focused with their attention towards self. So most of the things you're going to look for there are going to be how they engage you in conversation. Is it all about their own needs? And is it all about what you can do for them? Do you feel like an instrument or an object? Do you feel like an audience for them only, and like you're a fan? If so, if you get that sense, notice that, see if you can redirect. If you really think, well, maybe I want to give this a minute here. I really enjoy this person's company. And, you can see if this is something that sticks. I would encourage that you do that relatively expeditiously, right? Like somewhat quickly, if you are really concerned about that. If you're already in a relationship with someone, and or have children with someone who has NPD that you think, right, I can't diagnose someone I haven't met, and you can't either, to the audience of it, but you can really look into getting some therapy for yourself. Often people with NPD will be hesitant to go to counseling, or will go and deny things, again, like this is just some anecdotal stuff, and you can find a lot of information out there about it. But I would encourage you, try to get some professional help for the situation, because that'll do nothing. At least it won't, at the very least, it will give you validation.
Well, right? And it brings to bear the very true fact that all we can control is ourselves. And so, yeah, if and it's interesting because one of the listeners that sent this to me, you just explained beautifully what happened. Counseling came into the situation, like premarital counseling, and it all went to it all hit the fan essentially, because he probably does have NPD. I don't know, but I will, just as a means of housekeeping, put the link to the American Psychological Association DSM-5 in the show notes, because the criteria of many things that we'll talk about today is there. Well, that moves us into something. So, Jeremy, one of the things that you're doing, I'm loving that I'm seeing that what you're doing on Instagram, and guys, follow him. And again, just like last week, there'll be a contact Jeremy button, which is going to put you to his Instagram account, What Jeremy Fox Says. And I noticed one of the ones that actually caught my eye the other day as I was scrolling through was you were talking to your followers about intrusive thoughts. And I think that is something, and I did have a couple people ask me what, everybody knows what intrusive thoughts are. It's just a thought that I don't want. And particularly those of my listeners who have PTSD have thoughts that they don't want. So could you shed some light on some practical ways to move through those, like you would want to do if you had a 30-minute Instagram reel that you could do instead of 3 or 2? I'm not even sure what it is actually.
And what's interesting is I do have the ability to record longer stuff, like a whole episode about a topic. But truth be told, a lot of short form content is king in many ways. And I think if you know a topic well, you should be able to communicate it quickly, right?
Sure.
So that's also a thing. So I appreciate your glowing words there. Absolutely. So intrusive thoughts, you're right. I think people do have an idea, if you say it to most people, of what that is. Now, whether that's something everyone's on the same page would be an interesting thing to get to, right? Because I actually work with people who have OCD. So people with OCD, like harm OCD or contamination-based OCD, obsessive compulsive disorder, right? We'll talk about the intrusive thought that they need to take a shower, or the intrusive thought, right? That's an obsession, right? So we could say that some people refer to intrusive thoughts as reverse. People will refer to obsessions as intrusive thoughts, and they are. So they're intrusive impulses for sure. And they want to respond with compulsions or the rituals, okay? That, take that shower or shake out the thought of XYZ, whatever. That's a very common one, is doing something to remove that. And actually that strengthens the fear of that intrusive thought to like that you might hurt someone, harm OCD, right? The fear of hurting oneself or others. Again, that's very common, the fear of losing control and doing something that you would never do, like harming someone. So I work with clients who have that. And one of the therapies that's best is exposure, response, and prevention, ERP. Now, it's kind of what it sounds like. You're exposed to that thought, okay, that intrusive thought. You don't do anything. You just park your attention on that, ride the anxiety wave upward until it goes down, okay? But and that, so desensitization-based therapies. You'll notice I haven't brought up EMDR yet, which obviously I'm going to. I just did. But there's other therapies that help you to expose yourself to the negative cognitions and then ride them out. So obviously you're not going to do an entire session of that on yourself without a therapist, I hope. So what can you do day to day for intrusive obsessions or intrusive cognitions related to trauma? Well, for one thing, grounding exercises like the 5 things exercise, where you notice different things in your environment, you notice, and there's different, I think, scripts for that, but essentially the gist of that exercise is you notice 5 things you can see, 4 things you can hear, like you count down by the senses, right? But the key element there is to notice what is in your environment that you can touch, taste, smell, hear, see. All of those elements there of touch, of the 5 senses. And even you can add on, what are you feeling in your body? That interoceptive sense, which is another sense we don't talk about a lot. It is an inner sense there of noticing what you're feeling in your body, putting your hand on your chest and on your stomach and doing diaphragmatic breathing and focusing on your breath and heart rate. That will help with intrusive thoughts. This is going to take practice, everyone. Just to throw that out there, that's a huge objection. It's like, well, that didn't help right away. Okay. No, it's not going to. I'm going to be completely authentic with you, because you didn't get terrible intrusive thoughts that were that upsetting all at once. It snowballed out of an initial kernel, and it snowballed into something huge and upsetting and terrorizing. And so intrusive thoughts operate on the logic of thought, which is the logic of presence. And so when you, not presence like for Christmas, but presence as in being. And so if you say, don't think about a pink elephant, you will think about one. So you can't tell yourself, don't think about me going wild and hurting people I know I'd never hurt. It doesn't work. You're thinking about it. Instead, what are 5 things I can see in this room around me? What are different things I can touch, taste, smell, and go from there and use new thoughts, right?
Yeah.
Put center and make present another thought.
Making it here and now. Yeah.
Yes. And I mean, different brain regions are thought to be involved in intrusive thoughts, like the amygdala, which is the brain's fear center, the hippocampus, which is a key structure in formation of memories, prefrontal cortex, which is higher order cognitive functions, anterior cingulate cortex. I mean, I could go over and over. So you're not, I don't like the word crazy, but people certainly aren't crazy or mentally ill for having these things. They're human, their brain region, what we would call the things that are implicated in the brain that happen due to trauma. And trauma is what happened to you. It's not something wrong with you. And OCD can be just different brain regions that are overactive. Because people know, like, well, this is a wild thought. I would never do this, or I don't like that I'm thinking about this. And that's good that you can actually recognize it. You can say, well, this is a weird thing coming. Our brains are association engines. And so when we notice like a high play, there's something called the call of the void. And it's like and it's a very heady sounding term, but it's essentially like when you're at a high place and you get the urge to jump off, it's like, well, that's the brain hates suspense. And so it's like, well, there's this high place, like I could fall off. They're like, wait, you're not suicidal. Don't worry. There's a reason for that. It's like your brain is calculating and thinking of different things that could happen at this point. It's like a natural fill. Our brain fills in the blank.
Yeah. Yeah, that's so good. So much to unpack there. But I think the most important takeaway that you is identifying them as half the battle. And particularly for the trauma related intrusive thoughts or flashbacks or whatever, like sometimes the most random thing, I get them at the most random times. And I almost like shake my head like etch a sketch like that. But
Right.
that list, that 5 senses thing or listing, but you said something there that I just I'm gonna just say what I'm gonna say, and then we're gonna move on because I want my listeners to hear this. You said something really interesting there. You said when you get the intrusive thought, and I had not thought of intrusive thoughts by way of OCD or obsessive compulsive disorder. I thought more trauma and intrusive thoughts because that's my context.
Right.
But you said, but you encourage the listeners to ride the wave of anxiety. And don't, like you said, I can't think about that. I can't think about that. Well, that's all you're going to be thinking about.
Right.
And then your body is answering those signals too. And so to sit there and go, no one, and maybe I'm wrong about this, but no one that I know ever died of an anxiety attack, even though you feel like you're going to.
Yeah.
If you are committed to that healing and you can ride that wave of that intrusive thought, then that's when real healing can come by way of various therapies. And we're going to talk about EMDR, like you said, in a minute. But I wanted to just highlight that because we are wired to not want pain. And so we're going that's why we have drug abuse. That's why we have all the things. That's why we run. That's why we do things, because we don't like pain.
Yes.
Right? So I think that's really important to highlight. One of the things, Jeremy, one of the very first things I heard you talk about on the Clubhouse platform, which I'm not even on anymore, but that was you're one of the best gifts from that platform. But one of the things that I remember hearing you talk about, and I want to highlight it for the Wednesdays with Watson podcast listeners, was the association between perhaps maybe a misdiagnosis of attention deficit hyperactivity disorder or AD or just ADD and PTSD. Now I'm getting into the thing that you love to talk about. So talk to people out there who maybe are, and by the way, I really wish people would stop walking around saying I have ADHD, I have ADD, I have OCD. It's so, while we're in Mental Health Awareness Month, it's another free Watson nugget. Stop making jokes like that, because if you really know what it's like to be OCD, then you wouldn't make a joke like that. Same with ADD or ADHD. But why sometimes do we need to look a little bit deeper for a PTSD diagnosis for kids or vice versa? Yeah,
absolutely. So one of the biggest things to do is take your child to someone who's qualified. And I know the waiting lists now are very prohibitive for that. But the reason, so PTSD is going to be generated by a key event where someone either encountered a brush with death or saw it happen to someone else or had some massive bodily harm perpetrated or witnessed it, or what, you get the idea. So there will be a triggering event for PTSD, and feeling states, okay, will be active in that person when there's a cue, reminder, or trigger. So, and we were talking about senses, okay? So the negative way that traumatic reminders intrude on our senses is someone smells or sees or is touched in a way that reminds them of a horrible event, and then they go into that, and there's a fight or flight response. And so the issue here is, so I could skip all over the place, but with children, they're not always going to be able to report the event, and they might not use the same language an adult would. So it's important to determine if you think something occurred that might have sparked some of those symptoms that can be confused. So overlapping symptoms for ADHD and PTSD would involve issues with concentration, obviously, trouble sitting still, impulsivity, okay, doing things that you feel like the kid's acting on autopilot or can't mitigate, can't stop their impulses, all right, or task completion issues. So there's an overlap and an inattention and hyperactivity between PTSD and ADHD. I mean, there's a 2012 study in the Journal of Psychiatric Research that says that. So, and there's some similar structure and brain alterations in ADHD and PTSD. So prefrontal cortex, limbic system, differences there compared to neurotypical functioning. So hyperarousal can be implicated there. That's a thing that comes to both. But with ADHD, that's typically restlessness, fidgeting, difficulty with quiet activities. For PTSD, there's going to be hypervigilance, meaning being extremely aware, hypervigilant, okay? Exaggerated startle response. So someone with ADHD might not jump at being startled the same way someone with PTSD is, right? And insomnia. So that's another thing that can put PTSD on your radar is child may be afraid to go to sleep because of some fear of what could happen. So there's going to be a fine line there in diagnosis. And so the way that we can tell these things apart is going to be through questioning. And the older the kid gets, or if this is an adult, then obviously you're going to be able to explore more and have some abstract thinking and determine, was this kicked off by something? Does my inattention look like hypervigilance, or does my hyperarousal look like hypervigilance, or more restlessness and being bored and or leaping from one interest to another? So it's going to be an origin point issue. And Joel Nigg, N-I-G-G, is a really great expert on ADHD. He's got a book called Getting Ahead of ADHD. I highly recommend that. A lot of my info that I got back then on Clubhouse and was referring to is from him. He's got articles out there. He's ADHD and emotional trauma is one of his works that I would refer people to.
We'll put that in the show notes. I think it's just, I love, I remember when I heard you say it originally, it was a little bit groundbreaking for me because I was never as a child labeled any of those things. And now I'm a little bit older than when it kind of became sexy to diagnose that, but nor did I have any of the, like you said, that we need to go back to the origin point. And of course I didn't tell anybody. And I struggled with math, for example. And so, but that is, I think that is worth exploring for parents out there. And like you said, for adults, you can ask them, did something trigger this? Because you may in fact have PTSD and not ADHD, and they're treated differently, right?
Yes. And one thing I would say is, I mean, this is kind of a homespun answer, like very practical and anecdotal, is if someone responds well to EMDR therapy, which we'll get to, of course, and that you focus on a trigger and desensitize that, okay, and their attention symptoms go away almost completely, you're probably dealing with PTSD. But if someone has ADHD and you unspool their history, their narrative, and you look at as a therapist and you have them float back to the first time they felt that excitation of ADHD. And of course, people don't have encyclopedic memories. Most people don't. Some people do. Everyone doesn't. So if you float back and it's like, nope, I'm not getting anything traumatic, and the person's not able, no matter what. And I would say not to like have them painstakingly focus on everything bad. That's not what we do anymore. But if we have a good idea that after careful clinical analysis, there's not an abusive or life and death situation that occurred that launched this, you're likely dealing with ADHD. But EMDR therapy, when you desensitize through EMDR, those targets that keep that hypervigilance, that constant need to stay aware of the present, which can get in the way of deep work or deep focus. When that clears up, when you do EMDR, you've most likely seen traumatic induced attentional deficits there.
Gotcha. Yeah. And we are definitely going to talk about EMDR when I kind of end with that somewhat. But and we've talked about it quite a few times on this podcast. One question I got that I could actually really what's the word I'm looking for? I could relate to this question.
Yeah.
Is somebody sent in this question is like, how can we explain to our families that there's certain things that we just can't do because we have PTSD? And this actually recently just happened to me, and I had a family member say to me, Amy, you're not a victim. And I was like, whoa, I was just saying that I made this decision based on some things that have happened in my past. And so I need to protect myself because I have, I have PTSD. And my family member just was just like that. It's almost like, and I've heard this from many people, they just want us to move on.
Right.
And they don't understand that nobody wants to move on more than we do. Nobody on this planet wants to move on more than a trauma survivor. But it's not quite that easy. No. So the question that came in was, how do we talk to our families about this? Like if we had cancer, they would have all of the mercy and grace for us in the world. But we have PTSD and we need to just move on. So that was a question from a listener and from me, actually.
Well, I love that. And I really want to give it my best. Is there any kind of a hint of an example I could get? Because that's going to determine my answer. Like, is
absolutely. I'll give you my example. Yeah. So I'll give you my example. So when COVID hit, I thought I was going to lose my business, and I kind of actually was not on any medication until COVID hit, and it triggered for me Maslow's hierarchy of needs. Like for listeners, for those of you, that's basic stuff like food, water, shelter. I freaked out. I had no reason to freak out. I had a job. I have a master's degree. It was not logical for me to freak out, but I freaked out. Yeah. And so made a series of decisions, including going back to school to get my doctorate degree so that I had a future that was not connected to a business that COVID could have killed, but didn't. Thank you, Jesus.
Right.
And so I was sharing this with a family member that I made these series of events, and this one of the decisions that I made, this person didn't like. And so I said, I know what it's like to not be able to eat. I know what it's like to have no power. I know what it's like to this. I know what it's that. So I made these series of decisions for that reason. You're not a victim here. That's laughable that you would think that you're never going to eat, or that you wouldn't have a roof over your head. So if whoever sent me that question is experiencing that, let me tell you, that was and is incredibly painful. Right. To have that fear called laughable. And so we have some very real fears, and mine is food and water and shelter, that most people don't understand. And for it to be called laughable was just so painful. And so this wasn't originally my question. Somebody else sent it in. But right. I'm guessing it's stuff like that. Like I can't go to that NASCAR race because the sounds, if there's a wreck, I was in a car accident, or that, if it backfires, a gunshot might trigger me. I can't do some things because they trigger my PTSD. And most family members are like, screw it, move on. You're weak, move on. How do we just invite them into, imagine what it would be like to do the scariest thing ever and somebody telling you that's laughable or you don't have a reason to do that. And so I don't think a lot of family members understand PTSD, and that's been the point of this podcast. And so, yeah, I don't know if you have anything for us on that. If you don't, that's okay.
No, I mean, I do. I'm going to go, and I get this a lot. I get these sort of questions often. And if you say as a therapist, you don't do relationship therapy or couples therapy, my joke on that is you do. Everyone does. We all do relationship and family therapy, even if we strictly see individuals. Well, why is that? Because people are going to ask us questions like this. People are going to ask difficult questions about difficult people that have difficult answers. So if someone, and just think about it, if you heard that, if you, Amy, are hearing that listener submitted question, like if someone says, that's laughable or get over it, I mean, what would your first response be? Like, first of all, that's a very dismissive, kind of rude response from the jump. Like, that's not an appropriate thing to say to someone that we love anyway. And so the question is, how can I make someone in my family who talks to me that way stop talking to me that way is the real question. The question behind the question. That's what we often do as therapists is we'll hear things like, well, how can I make I'm exaggerating, but like, how can I make a loved one not tell me that my ideas are completely stupid and that I'm an idiot? Like, how can I stop that? It's like, oh, okay, grad school doesn't tell you how to do that. So, but what it does is different kind of books that you can look at, like how to have that difficult conversation. I think that's, well, I don't want to cite that improperly. I'll find some resources for that. But one of the things we can do is, first of all, and like Verbal Judo is a really good book, by the way, for emotional conversations and for things that are difficult like that. Dialectical behavior therapy, interpersonal effectiveness skills are very good. So we'll actually do that really quick here and go over it. So when we're having a conversation, okay, we can use the Dear Man acronym, which stands for describe, express, assert, reinforce, be mindful of your goal, appear confident, and then of course negotiate. So those are things that we can do. And again, we can add a list at the end of the podcast, but describe what is bothering you. Like, I have a condition that I'm working through, and hopefully you are. That's a big thing, is you can actually desensitize a lot of the triggers. Now, it might take time, and I'm not telling you go fix yourself for your family. First of all, I wouldn't refer to people as broken or fixing. Second of all, I think that any healing should come from a motivation for your own enrichment of life, right? So I don't want people to have to live with their triggers. I mean, that's very burdensome, but describe that was something that you want to talk about, like describe the facts of what occurred in that communication with your relative, okay? And use I statement to express your emotions about that. Like, I'm feeling misunderstood, or I'm feeling hurt when you said, get over it, you're not a victim, or that's laughable. And then you can assert, you can clearly state what you want. Like, I would prefer for you to not refer to my needs right now as laughable or XYZ. And then reinforce. So reward the other person, or explain, like, I'll be glad to go with you to this other event, or I'd love to join you for this. That might be more of a thing when negotiating with family.
Yeah.
Right. Is offering to go in and do something. I mean, when it's something related to communication, like your own preferences, then the reinforcement is really that you'll continue to be around that person, or maintain the same status quo, the same status in your relationship, whether that's with your mother, your friend, your father, whatever. And be mindful. So if someone throws in their experiences that they've had, or, I've had trauma too, and I don't let it rule my life, or something else toxic like that, you say, well, right now we're talking about this issue that I'm having, and I really respect your concerns, but I would love for you to understand this about my condition. So, appear confident, that's huge. So be able to calmly explain what you're expecting. And that, again, it can be helpful to talk with a therapist or a friend that's, I say that very cautiously because all friends are not equally mature and being able to talk about this stuff. But you can workshop it, you can role play it, you can talk about it. And because if it's someone who's regularly dismissive, then you're going to be doing a lot of emotional control and expectation management with yourself, because you're going to be aware, like, I can't stop this person from reacting poorly. All I can do is say what my expectations are and stick to them. Okay. Yeah. And then negotiate, be willing to listen to someone else's side and even get outside your comfort zone a little bit if clinically indicated, and it won't cause you to decompensate. And if you think that it's possible, again, all that stuff, I'm not giving clinical advice here. I'm not telling you to go against and do desensitization on yourself with your family or friends, but negotiate on certain things if that would be helpful. Like wherever that might be, it certainly might not be exposing yourself to flashback triggers, nor would I expect that or advise it. But anything that's negotiable, like doing something your friend wants to do besides whatever would evoke your flashback. There you go. That's a good example. So as far as explaining
it's a great example.
Well, thank you. So as far as explaining PTSD in the most simplistic way you can for people who don't have a neuroscience background, or you don't think they want to hear it, honestly, you can explain that certain memories, when you're upset enough, get stored in an upsetting way that when you're afraid for your life and you're under mortar fire in the military and you hear that sound, the sound is stored connected with intense emotion because your prefrontal cortex is not as active as your amygdala, the fear center that we talked about earlier. So that doesn't just happen with veterans, by the way. Like, military is not the only thing causing, military experience is not the only thing causing PTSD. We know that, but that's an example I could use. Or a car accident, like that's another one. Something that, you know, if someone's tailgating you, you're really upset because you got rear-ended really hard and you saw the car behind you right before that moment of impact, and that image is stored with that emotion. So explaining to your friends, like, or family, I had an experience occur that was so upsetting that this sensory element was stored with the emotion intensely, and that's what trauma is. And I'm working through it, but right now, the different things in my environment that remind me of the incident are very emotionally disturbing. So that's something. And again, if people don't want to come off of their own expectations, they're not going to come off of them. If it's all about someone else's convenience, and that's where we get into narcissistic.
I was just getting ready to say, and we full circle back to narcissism.
We do. And the painful thing about it, and that's again part of therapy, is bearing witness to people's pain, even when there's nothing to be done. You can't change narcissistic family members. There's no magic words. People want, if you have a fixing brain and you want a formula and you're really good at school and you love improving things, you're going to want to get a formula for changing someone that you think is a narcissist. I hate to say it, that right now, as far as I'm aware of in medical science, is not possible. Plus, it would kind of be unethical. But I mean, even if it changes someone's narcissistic personality, or that's their personality, they have to consent to that, right? But what is possible is, people with narcissistic personality disorder can have empathy. And so I would say not to get in a tug of war where you're trying to appeal to that and begging, because that gets you right back where you don't want to be. But if they're open to changing and they're aware that you're no longer going to indulge negative behavior, then you have a good chance of getting an answer to that. The gray rock method is very good for dealing with people with NPD, by the way. You act deliberately unresponsive or unengaged so that someone who thrives off of your responses will lose interest. So, like, you're just staying. Have you heard that before?
No, it's just that I just heard that in real time. That is absolutely fact. We're going to write it down. Fascinating. It sounds to me like it's in terms of family, especially in my situation. And I'll own it. I basically, what it did was it hit my nuclear button. I was so angry, yelling at the top of my lungs, like, I can't believe you just said that to me. And it is unresolved. And this person has asked for another conversation with me, except for she came to me with, I said what I said, I stand by what I stand by, let's talk.
Sure.
No. And so this is where, and we don't have time to talk about boundaries because I really want to talk about EMDR. So think about what Jeremy is saying here in terms of, if you are dealing with somebody like that, even if they're family, if they're unreasonable in that they will not respond to you with you come in with your hat in your hand, like, hey, I had something that happened, and the beautiful way you just articulated that, I'm working through it, but for right now, I'm worried about whether I could pay my bills. And I know that doesn't seem logical to you, but trauma isn't logical, and I can sit here and tell you why your brain can't do certain things without EMDR. And so this is a beautiful segue into EMDR. Of which Jeremy, this is his modality. There, I am, Jeremy. I just started my next class in my doctorate program, and it's theories of counseling, so it's all of them. And so we get to pick one to do a presentation on, and I'm going to do it on EMDR because duh. But I'll learn all of these different ones. And so, but Jeremy is in the Atlanta, Georgia area. Again, his contact information will be there. I don't know if he's taking new patients, but he's an exceptional therapist. And so EMDR, a lot of people put some mystical stuff with it. Like, are they trying to take control of your brain, or actually what's going on? And so this was a modality that was really created by mistake by Francine Shapiro, who was having a distressing moment in her life. I think it was a cancer diagnosis or something, and you might be able to correct me on that, Jeremy, but was in a park and in New York, I believe, and noticed when she looked to her right or to her left with birds, their wings flapping, that the intensity of the emotion that she was feeling was not as bad, because she was engaging both sides of her brain. So I kind of set that up just a little bit because I want to use your time for the stuff that I can't tell them. And so for PTSD, exposure therapy is the gold standard, I think, anyway. And EMDR is a safe place to desensitize the memory, because it essentially is exposure therapy. We're being asked to go back to the traumatic memory and then processing it to desensitize it. And that's where you come in to tell us how that happens. So cool.
Yeah, there's multiple different theories for how that works, right? So the working memory hypothesis has a lot of traction now. And there's some really cool research on that out there if anyone's interested. So the same way that you have a computer open with multiple tabs, and when you do that and you try to play a YouTube video, it goes slower or lags when you have the memory of your computer bound up in all of that open information. EMDR works a similar principle of what the working memory taxation. So you're taxing or straining someone's ability to pay attention. So it's funny because we're talking about ADHD. So we're inducing a bit of a sense of we're dividing attention. So EMDR therapy refers to the entire model from treatment planning to reevaluation, where we ask about a target and see if there's any more emotional valence, or big fancy word for emotional vividness there involved. So what people mostly think of, and what we talk about a lot that's got the mystique behind it, is phase 4 reprocessing, desensitization, where we have a client bring up via a series of questions, what are they noticing? What's the cognition? What are the emotions there? All that stuff connected to a traumatic memory. Okay, what makes it traumatic is that fight or flight response being active, and the way the memory was stored is state dependent, is really with that emotion attached, right? So getting a memory like that and dialing it up, I call it, as activating it is what is another good term that my trainer friends in EMDR use. And having someone watch our hand go back and forth while our face is off the camera, if it's remote or in person, doing hand gesture, doing bilateral side-to-side hand movement to strain that ability to fully notice that emotion, right? So we're constantly titrating in, like an IV, the present in the form of hand motion, or these really cool hand buzzers that are tactile and keep someone in the present by vibrating their hand and telling them you're here, you're safe, while you're thinking of this memory. So we do that with the client until the memory goes from whatever score it is to a 0 in the subjective units of distress or disturbance, SUD. And we have the person, we constantly check in after what we call sets of bilateral. So we're processing that memory with someone, that's where the reprocessing element comes in, is we're taking it, we're desensitizing the emotion, and the brain will often reconsolidate that memory, meaning store it differently and in a form that's more semantic and not the physiological response attached to it of distress. Someone will often connect it to another earlier life event and say, oh, this reminds me of a general sense of powerlessness that I have. And so that memory's been reprocessed, stored differently, stored in context as an event and not a fear that comes up in the body now. So
yeah, my doctor says, and he's so right about this, is that EMDR takes the uber pain out of the memory. And so, like, when I think of the very first thing we reprocess, the very first memory we reprocess, and listeners, I want you to know it's so cool because you set there's a safe vision there's a safe picture in your mind. There's all kinds of parameters to keep you safe, right? Because you're talking about something I mean, I threw up, full disclosure, the first time. But the very first time that we did it, it was about my domestic violence situation, and we processed through it. And now when I think of my domestic violence situation, I think of one of the truths that we weave. And so at that point, he was patting my hands, but now he has cool tactile things you're talking about.
Yeah.
And 3 words came in my mind: you deserved better. And so now every time a trigger will come up from my domestic violence, there's 3 words come to my brain, period. And so it does take the uber pain, like it, instead of no longer the Etch-a-Sketch, like I'm shaking my head, I don't want to think about that, to we process that, it's put to bed.
It's done. Yeah. Well, and some contemporary research that's really interesting says that EMDR replicate the bilateral saccades, we call them, or side to side movements, replicate slow wave sleep waves. They activate those, which binds memory. And that gets to how EMDR therapy essentially does the work that's supposed to happen during sleep, where the memory is stored with its important elements, but otherwise released. And again, I'm trying to keep this very comprehensible and comprehensive. So we know that EMDR works through different studies that we've seen that have shown evidence that the memory is taxed, working memory, meaning how much we can have it mined in any given time, and brain waves active. Slow wave sleep waves being active during bilateral stimulation. Like, what's that all about? Why is that happening? Fascinating. So you can go deeper with that. It is. And so there's people will say there's hemispheric connectivity between left and right hemisphere. There's different research on that. But I'm citing the stuff that I'm most familiar with, that I've written about.
And empirically, I can tell you that, and I've told you this before, that I had an MRI on my brain, and I can't remember why. They found 5 lesions in the frontal lobe, and they were like, it's probably just your age. And I was like, well, I thought that's not cool. I'm not that old. This was probably 10 years ago. And I said, but they said, come back in 6 months. We'll make sure that it's nothing. Well, I went to my psychologist, Dr. Pettit. I was like, game on. Like, let's pick up the intensity of EMDR and let's see if this MRI will change. And I had 9 of them, and 5 of them disappeared with EMDR. Right. And so it is very difficult on a podcast to talk about. I will be talking about it a lot in the coming season, as it is something that I'm probably going to end up. My dissertation topic might be EMDR related-ish. And so this is how much, guys, it matters. And so I want to give you the mic, Jeremy. We're going to I always love to give you the mic at the end. I do want to talk about other alternative treatments like cannabis and psychedelics, but we're going to throw that up on the YouTube channel. So we're going to close the audio part here by giving you the mic, and then those of you who are interested in Jeremy's answer on alternative treatments for mental health. And I am specifically talking about cannabis, MDMA, which is ecstasy, and maybe one of the mushrooms that are being used to help and effective in some major depressive disorders and things like that. But that's going to be only on our YouTube channel. So, and that will be in the show notes. So for the audio portion, Jeremy, the mic is yours. I cannot thank you enough. This is the second week in a row. We have had an hour-long conversation for my client or for my listeners. And so one of the things that I'm learning in school is that it's jobs of the therapist. I'm not going to be a therapist. I'm going to be the coach to the therapist and help you guys with intervention strategies and stuff like that. But every class so far has said the number one job of the therapist is to instill hope. And that's what you've done here today. And so the mic is yours, but I wanted to throw that in there because there is hope, guys. And EMDR is one of those hopes, but mic is yours before we exit off the audio platform.
Well, I am surely thankful for that. I think one of our biggest jobs as therapists is hope generators, right? We have to give people a reason to continue forward. So with clients who have horribly oppressive depression, then what we have to do is explain to them, like, you're not alone. This is a condition that affects millions of people. Same with anxiety. This is something where we have a coded, right, diagnostic set that can be validating, like, because that's your starting point. You recognize then, oh, these things exist and not just in my mind. Like, I'm not the only person dealing with this. So when you realize that, and you realize that there's interventions that help, like EMDR therapy, okay, and you recognize that trauma is like a splinter, your traumatic memory that keeps coming up that can be removed. There is hope. There's healing. Trauma, PTSD all the way to, complex PTSD at the far end, which is just severe repeated episodes of abuse that cause your actual personality to change, you not to trust people, et cetera, on one end, all the way to more minor things that don't reach minor, in quotes, that don't reach the PTSD criteria. All of that is treatable through desensitization and reprocessing, and people realize that, right? It's so powerful, and I want listeners to know there are answers for so many conditions now. We talked about OCD, which can be extremely tricky to treat because there's that obsessive quality to it. Sometimes clients will be on the fence of, well, do I want to do this ritual just because it'll be easier? Do I want to stand up to it? There's that pernicious maladaptive element there where it becomes easier to just go along with the disorder than stand up. And I'm here to say, when you recognize that you can walk through this with a professional in session and overcome this together with someone else, you get more energy. You will have more energy to do that because two people will be working on your problem together. So that would be where I would probably want to end.
You just gave me you just gave me chills. That is insanely hopeful. Two
Awesome.
people will be working on your problems, and that you just gave me chills. Well, guys, if you're listening on the audio platform, we are headed over to YouTube so that he can answer this last question. Jeremy, thank you so much for being here on the Wednesdays with Watson podcast. Guys, we will be back in 2 weeks. June is National PTSD Awareness Month. Got 2 episodes queued up for you there. One of them is the PA that works in my psychiatrist's office, and I am doing a program with her right now called Listening to Your, or she's calling it When Your Body Speaks. So she will be here with us, and then I will have a good friend of mine who is living with PTSD, and it's just going to be 2 girls with PTSD talking to you guys so you can continue to help understand it, as that is our mission here. So for those of you who are on the audio platform, we will see you in 2 weeks.
Here I am, you can see that I'm nowhere near where I want to be, but you remain